Our second speaker this afternoon is the Assistant Professor of Clinical Medicine at the Division of Pulmonary and Critical Care Medicine at the University of Miami. He has been an active researcher in COPD and Alpha-1. His areas of interest are both the pathophysiology, I knew that would mess me up, of Alpha-1 and the prevalence of Alpha-1 in Hispanics. Here to discuss with you other clinical conditions associated with abnormal Alpha-1 genes and the signs and symptoms associated with them, please welcome Dr. Michael Campos.
Thank you very much. It's always a pleasure to come to the Alpha-1 Association meeting. First warning, I'm going to talk about some rare things, and I don't want you to start feeling that you have those things. That's something that happens, right? And you hear about a disease and say, oh, maybe my joints are hurting, my chest is hurting. But please, just take it with a grain of salt. And I tried to put together what's out there in the medical literature about rare things associated with Alpha-1, and hopefully will help us understand more what Alpha-1 is doing in our body and also the importance of this protein. So the 101 about Alpha-1, and I know most of you know this, but it's always good to remind you, is that Alpha-1 is a protein that does a lot of good things in the body. It's a protein that has some sugars attached, and medically we call this a glycoprotein. And it's made mostly by the liver, as most of you know. But other tissues also make Alpha-1, which gives us an insight that Alpha-1 is doing more things locally. For example, it's produced in the lungs, it's produced by the cornea, it's produced in the joints, and we still don't know much about why that happens. We're working on it. And its primary purpose is to target neutrophil elastase, as probably you heard many times. So in this cartoon, it's just to show you that the liver is making a lot of Alpha-1, goes all around the body, and especially goes to the lungs, and protects the lungs against the neutrophil elastase. So just as a cartoon, for those of you who don't remember how the lungs look like, you have the bronchi, and it starts branching out all the way down to these small air sacs that we call the alveoli. And that's where Alpha-1 is doing a fight, is trying to protect the lung against these Pac-Mans. And these Pac-Mans are other proteins that are released by these soldiers called the white cells. Now, these soldiers start shooting the Pac-Mans because there is injury in the lung. And the injury usually comes from cigarette smoke, but can come from bacterial infections. So when the lung has this problem, the soldiers start shooting the Pac-Mans, which are good. We need those Pac-Mans. But if we have too much activity of Pac-Mans, the Pac-Mans start chewing the lung. So that's when Alpha-1, which is considered a protease inhibitor, kicks in, trying to inhibit the Pac-Mans. So this is the classic role of Alpha-1, to protect the lung against the effect of these Pac-Mans, which we call neutrophil elastase. I'm going to change pointers because this one is not working. Okay. So this is what I told you, Alpha-1 protecting the lungs, but what you have to imagine is Alpha-1 protecting the whole body, because it goes into the blood and it goes everywhere, not only to the lungs. So what are the functions of Alpha-1? The first one is inhibiting this Pac-Man, the neutrophil elastase. But we know from recent studies that Alpha-1 is also regulating the amount of inflammation that we get in the body. And these studies have been done in white cells and in blood vessel cells. We know that if we injure a cell, there is a response. The cells react to this with something that we call inflammation. And when there's Alpha-1 involved, this inflammation changes. It can nearly go down. So most of us doing research, we're now considering Alpha-1 as an anti-inflammatory protein. Now, Alpha-1 can get inside some cells in the body and prevent them from dying. And that has been already shown in pancreas cells, and that's why some people are thinking maybe we should give Alpha-1 to diabetics, because it will protect the pancreas cells that make insulin. And there's future research coming in that area. It also protects the blood vessel cells from dying. So this is what's coming out. So as you can see, alpha-1 is doing more than just knocking down elastase. There is some new studies showing that alpha-1 may be involved in regulating how much fluid you have in your airways, the amount of secretions that you produce. So alpha-1 is a molecule doing more than just knocking elastase, and I think that we're learning more as research gets advanced. Now, in addition, when you have abnormal alpha-1s, for example, the Z protein that I know most of you have, the Z protein can clump together. And that's not a good thing because the clumps, they attract neutrophils, attract these white cells, and create more inflammation. So if you put all this together, you say, well, maybe if you have deficiency, you're going to have other organs involved, and maybe alpha-1 will produce some rare manifestations, and that's what we're going to talk about. Now, when I think about these rare manifestations of alpha-1, I was putting everything together and said there are two types of rare manifestations. One are the diseases that people think were associated with alpha-1. And why is that? Because when you do a study and you say, okay, for example, arthritis, and then you compare people with arthritis with people without arthritis, and then you try to identify if there is alpha-1 deficiency in one group or the other, and then you compare them and you might find something. Okay, that's an association, but that doesn't mean that alpha-1 is causing arthritis. So there are many studies like that. And the other one is diseases that are more clearly associated to the deficiency itself. Could be either because the alpha-1s are abnormal, the molecules, could be because the low levels of alpha-1 are already causing some damage in the body. And usually these are happening in both people that are carriers and people that have the two genes that are bad. So this is more or less what I'm going to start showing you from different studies that have been published. And for those of you who don't remember this, MM is the normal genotype. Alpha-1 levels, this is the alpha-1 levels in the blood. There's a big range of alpha-1, but this is considered normal. MZ carriers have levels that can be below normal, but can also have levels in the normal range. SS, SCs, they're clearly below, and ZZs, they're clearly below. So all of these are associated with what we call rare manifestations. And this is the list, long list. And they're in alphabetical order. Now, don't worry, I'm going to go through the list quickly and briefly so you understand what's going on. So first in the list is the ones in red, asthma, COPD, and liver disease. Those are the ones that we consider the common one, the usual manifestations of alpha-1. So I'm not going to talk about those. So they're out. Now in yellow, aneurysms, aortic degeneration, intracranial aneurysms, and some rare disease of the arteries of the kidneys. So I grouped that and I call them diseases of the arteries. So what evidence do we have? The two diseases that we find in the literature most commonly associated with alpha-1 are, one is this one, which is, you don't see well the human body, but this is the aorta that is in the abdomen. It's called the abdominal aorta. It can get dilated like this, and we call this an aneurysm. In medical slang, we call it AAA, abdominal aortic aneurysm. Now, this can grow and rupture, and the person can die from this. Now, there were some early publications showing that maybe people with alpha-1 have a higher risk of having these aneurysms. And also, aneurysms in the brain vessels, those little balloons here that can pop and break and cause intracerebral hemorrhage. There were some publications saying maybe alpha-1 is associated with that. Now, maybe, and we start thinking about it, is because the blood vessels have also elastic fibers in the wall. That's why the vessels can pulsate. And if you have deficiency of alpha-1, maybe there's too much elastase that will damage the vessels. In addition, risk factors to have this, for example, AAA, is smoking. And maybe if you combine smoking and Alpha-1, maybe you can have aneurysms. So what is the data between AAAs and Alpha-1? First, there was a study, a small study, 47 patients with AAA, that suggested that there was a higher frequency of Alpha-1 in this small population. But more recently, and just summarizing, there's studies from Pittsburgh, Pennsylvania, and London that said, no, that's not the case. And a newer one from a Swedish study showing that in 102 patients, consecutive patients that they found with AAA, there was not an increase in Alpha-1 frequency. So clinically, it has no clinical meaning for us that we work with Alpha-1, because one paper said yes, many said no. It makes sense to look for it if somebody is at risk, especially people that smoke. And there are current guidelines in the country saying that if you're older than 50 and you smoke, there should be a routine check for AAA. But I don't think that the association with Alpha-1 is that strong. But you will find this in the literature. How about the aneurysms in the brain? For example, most of these reports are from the Mayo Clinic that say that in 4 consecutive cases, they test for Alpha-1, and from 4 patients, 1 was an MZ, 1 was an MS, and 2 were an MCs, and 1 was an MM. Well, there's small reports. Another report from the same place, 3 consecutive patients, 2 were carriers. So as you can see, the reports are very small, and given the frequency of aneurysms, it's also nothing to be concerned. That doesn't mean that you'll need a brain CT scan or anything like that. So there are reports only. So how about coronary atherosclerosis, the #1 killer in this country? Well, there are some case reports that the coronaries can rupture in patients with Alpha-1, and I found like 6 cases in the literature published. But I found this publication from 2001 from Lithuania, that they did a big study of coronary disease and Alpha-1 alleles. And these are numbers, but if you see, this is people in the general population, and this is people with coronary disease, and they look for the Z gene. And if you can see, people with coronary disease have a higher frequency of having the Z gene. And they make an association. Also, as people get older, your Alpha-1 levels drop, and the risk of coronary disease goes up. So they try to make up a hypothesis. Maybe if you have the Z gene, you're at higher risk of having coronary disease. And at the same time, if you smoke and your alpha levels go down as you get older, maybe there's a higher chance. But anyway, as you know, coronary disease is so common in this country and all around the world that probably this association is, although it's interesting to think about the pathophysiology of this, is nothing to worry about specifically for Alpha-1. How about this? Arthritis, osteoarthritis, rheumatic disease, uveitis, inflammation of the eyes, and something called fibromyalgia. Medically, we consider these rheumatologic diseases. You see a rheumatologist for this. Now, most of the studies are very old, and case reports and case series. For inflammation of the eye, which we call uveitis, and for rheumatoid arthritis, the same thing. There are only cases associated with that. And these associations are weak, and there are other papers showing that there's not such an association, like the aneurysms. So this is kind of controversial. And there's no clinical indication to search for these diseases if you have Alpha-1. But if you look for it, you're going to hear about this. Now, there is one newer association that is more popular now. It's fibromyalgia. And what is fibromyalgia? It's a disease that we call idiopathic, which means nobody knows why you have it, that causes a lot of pain and stiffness. And most of this pain is associated with a lot of things that you can read here. People get fatigue, morning stiffness, they don't sleep well, headaches, irritable bowel syndrome. So it's a disease a little bit non-specific, hard to treat. How do we diagnose it? There are what we call the trigger points. There are 18 trigger points in the body, 9 on each side. that the rheumatologists look for each one of them and they start touching you in these points. And if you have a lot of pain, that's how they make a diagnosis. It's a disease, as I mentioned, very non-specific and not easy to treat. Now, the way it's treated is it's a long treatment, a lot of massages, a lot of heat, biofeedback, acupuncture, antidepressants, some medications, as you can see here, injections in those trigger points, and trying to focus on the sleep. There are studies that show that if you don't sleep, you can get fibromyalgia. But interestingly, there are reports of 2 cases where patients had fibromyalgia and Alpha-1. And as soon as they were starting augmentation therapy, everything went away. And then there was a shortage of prolastin at that time, and the symptoms came back. They started treatment again, and the symptoms disappeared. And then there was a big hypothesis now, and there are some papers out there suggesting that maybe all this pain, which probably has to do with nerve fiber inflammation, has to do with Alpha-1 deficiency. So keep that in mind, because I'm sure that more research is going to come from this. How about kidney problems? Now, kidney problems have been associated with Alpha-1, but all of them in kids. We call it glomerulonephritis, which is the medical term for kidney inflammation. Has been reported in kids, as I mentioned. The first report is 20 children with liver disease and Alpha-1 had a 79% prevalence of these kidney problems. And when they compared them with other kids with liver problems and without Alpha-1, those kids had it only at 43%. So there was a suggestion that maybe having Alpha-1 predisposes these kids to have kidney problems. And if you do a transplant, everything goes away. So there's dramatic changes when they get a liver transplant. So we have these reports out there, kidney problems, but mostly associated with children with liver problems, not in any children. How about neurological disorders? Now, I found this publication interesting, and as the paper says, this could be good or bad. And what is it? This is, to be honest, it was a little complicated for me to understand as a pulmonologist reading something that has to do with psychiatry, neurology. But what they did is they did these comprehensive tests to see how artistic is a person or how creative is a person. And they came with a concept that they call ICE, intensive creative energy. And they had Alpha-1 phenotypes on everybody. And I'm sorry it doesn't project well, but it's also small. The green thing is the creative energy a person has. Here you have MMs. These are MS, and you see more green. MZs, and look at the ZZs. So, now, wait a second. Now the bad news. Now, just imagine, when somebody is very creative, you know, these people that you call them hyper, or medically sometimes we call them a little bit hypomaniac, very creative, very intense, very smart. Some people can flip to the other side and get a little psychotic. And that's what, and that's what the publication was saying. It's a neighbor, that's what they call it, of being so creative is some people can go into that state. And they call it, it's part of the bipolar spectrum of disorders. So in this study, they did that association, and they found a higher incidence of anxiety and bipolar disorders more in the ZZs than in the general population. But has to do because the brains are very active. Now the artistic parameters were also way high, you know, when you have the Z protein. They cannot explain why is that. But they came with this Alpha-1 phenotype, which for me was also kind of interesting, but as I said, it's very hard to understand this publication. I don't know if Sandy read it and you understand it better. But they mentioned that traditional phenotypes is COPD and liver problems, but then they come with this phenotype, which is associated with some other things because they measure everything in the blood of these people. Vitamin deficiencies like thiamine, some hypoglycemia, the sugar goes down. They mentioned that people have more fatty liver. The copper metabolisms can change, and maybe that's why they're so creative. The mood disorder that I mentioned, they found a trend towards more attention deficit disorder, and later they found that people can have some cognitive impairment. So take it with a grain of salt. This is the first study I've seen this type. It's an association, but for me the most impressive thing was what I just showed you about being intensely creative and this. Okay, lung cancer. Probably you heard the news. It was in the Alpha-1 press lately. Most of these studies with associating lung cancer with Alpha-1 come also from a big database from the Mayo Clinic, where they had 1,800 patients with known lung cancer, and they compared the Alpha-1 phenotypes in this group versus people that were without lung cancer that live in the community and people without lung cancer that were siblings of these patients. So two controls. And they measure all these Alpha-1 alleles. They found S, they found Zs, they found rare types, nulls, Is, Ps, and Vs. And then they compare the frequencies. So what did they find? Alpha-1 carriers, they found a 70% higher risk of developing lung cancer when they compare with the community residents. And they found a twofold increase of lung cancer when they compare with the siblings. Now, as you know, most people smoke, and most of the risk cancer comes from that. Maybe Alpha-1 is doing something there, and they explain it this way. Maybe by having Alpha-1, there is more elastase activity left, uninhibited, and this elastase damages the lung, and by damaging the lung, lets the carcinogens stay longer in the lung, and because in COPD you get what we call air trapping, these carcinogens stay longer in the lung, and that's why the risk of cancer goes up. So it makes sense, but this is the data out there. It's just an association, just an observation. So this is what we have left, and these are the ones that we consider classically the rare manifestations of Alpha-1. We have paniculitis, we have Wegener's, and we have this bronchiectasis with non-tuberculous mycobacteria. And we consider they're rare, but they're on the radar, all to the point that when the American Thoracic Society recommended screening for Alpha-1, of course they said COPD, unexplained liver disease, should highlight we should screen for Alpha-1. They included people with paniculitis, a skin problem. And they call this category A. You have to screen these people. And they came with category B, encourage. And in that group, they included bronchiectasis, and they included these Wegener's, or we call it also C-ANCA positive vasculitis. So those three conditions are in the radar, are in the guidelines. And if somebody has those conditions, they need to be tested for Alpha-1. So what are they? Let's start with paniculitis. Paniculitis is a cartoon of the skin. And the skin has different layers. These are the sweat glands, for example. These are the hair. In the bottom of the skin, we have some fat tissue, as you can see here in yellow. It's called the hypodermis. Well, this area gets inflamed, and that inflammation is called paniculitis. How does it present? Red spots in the skin. And they may break down, and they can have an oily discharge. And the common sites are tight buttocks, but it can appear anywhere in the body, usually in sites of trauma. And some conditions can precipitate it, like if you hit your leg and later becomes red and the red doesn't disappear, it could be paniculitis. Too vigorous exercise can also do it. Some people get injections in the skin for whatever reason, and in the site of the injection they can get this problem. And it looks like this, red tender spots, kind of raised. This is, oh, it doesn't do well. There's a red spot here. But that's how it presents. Now, we have found that it's a rare thing, and Dr. Stoller from Cleveland Clinic, he did a couple of reviews, and he says that even if he looked everywhere, he found less than 50 cases reported in the literature. Probably it's more frequently because once you report a few dozen of cases, if you want to report another one, most journals are going to say, that's already reported. We don't want you to report. So probably it's more frequently than that. The estimated prevalence is 1 in 1,000 alphas, so it's rare. It has been described with ZZs mostly, but it has also been described with MZs and MS and other rare types. So it can happen just by having the deficiency. Now the Z polymers, as you know, the Z molecule can clump like this. This is a picture of how two molecules, the green one and the black one, clump, and they can form chains and groups of alphas. These are the Z alphas. This is a skin biopsy of a recent publication showing that we can find these Z polymers in the skin of people with panniculitis. So probably has a direct relationship with Alpha-1, as opposed to the other conditions that they're just an association. And the good news is that in this later report, this patient that they reported was treated with high doses of augmentation treatment. Most of us, treat with 60 milligrams per kilo. They gave 60, they gave 90, then they gave 120, and the panniculitis went away. So probably this is the way to go if somebody develops this disease, with more augmentation therapy. How about Wegener's, or the vasculitis? Well, Wegener's is a disease where there is inflammation of the blood vessels. And if this is the biggest blood vessel in the body, the aorta, blood vessels start branching, and then we call them medium-sized, small-sized, capillaries, etc. Wegener's are from here to here. So all these vessels can be affected in Wegener's. Inflammation of the arteries. We call it also Cianca vasculitis. Now, it's rare, but I think that most of us who work in big hospitals, we have seen more than 10 cases. And we should test for Alpha-1 when we see this because there's a strong association. As you can imagine, if your blood vessels are affected, anywhere in your body you can have a symptom. Now, the antibodies are what we call the Cianca. They're antibodies, which means that the body produces this antibody against our own cells. It's an autoantibody or a self-induced antibody. And this is how we diagnose this and a biopsy. Now, why does this happen? The antibody that characterizes this disease is against something that we call a proteinase. And we know that Alpha-1 is a proteinase inhibitor. So if we don't have the inhibitor around, maybe there is too much proteinase left. And if there is too much proteinase left, maybe there is more chance of developing an antibody against this proteinase. That's how more or less we think. So this is just a cartoon, what happens in the blood vessels. Your white cells, the soldiers that fight infections, they get attacked by your own antibodies, and then they start they start having dysfunction, and they clump to the sides of the wall of the blood vessels, and then inflammation happens in the blood vessel, and eventually that blood vessel shuts down. And that's how you get damage. This is just a picture of how it looks when you look in a microscope. Now, it can affect a lot of organs, but the common ones are the lungs and the kidneys. And you have a list here of symptoms. A lot of nose symptoms, ear symptoms, throat symptoms. We do x-rays, we can find spots in the lung, people can cough up blood, people can have kidney problems. And the blood vessels, as you can see in this picture, they're kind of shutting down with inflammation. Now, what's the relation between Wegener's and Alpha-1? This is just a summary. Studies from France, Sweden, Austria, Australia, UK, and Denmark showing that people with Wegener's, if you compare the Z allele frequency, versus the control or the normal population. For example, the population, you expect to have a 1.9% chance of having Z. In this study in France, they found 17%. In Sweden, they expected to find 2.4, they found 9%. In Austria, they expected to find 1.4, they found 10.9. So as you can see, the frequency of alpha-1 is much higher when somebody has Wegener than in a normal population. So that's why it's in the radar when we see this disease to screen for alpha-1. So although it's in the screen, it's uncommon, and the way we treat it, we give prednisone and cyclophosphamide, which is an anti-inflammatory drug, and we treat people for months. So there is treatment, but just remember that. And bronchiectasis, I left it for the end because it's much more frequent. And bronchiectasis is a condition where the airways get affected. And let's see if this works. I put a little movie here. Let's see.
And finally, into tiny grape-like clusters of thin, fragile sacs called alveoli.
So that's the alveoli. Sorry. Let me put it again with the audio.
Down the trachea and into smaller and smaller airways called bronchi. The bronchi divide into bronchioles, and finally into tiny grape-like clusters of thin, fragile sacs called alveoli. In alveoli, oxygen is exchanged for carbon dioxide in the blood. Bronchiectasis is an abnormal destruction and widening of the bronchi due to recurrent inflammation or infection. This results in the airways becoming abnormally enlarged. Extra mucus tends to form and pool in the enlarged airways. The small hairs that line the airways, cilia, are also damaged, affecting the patient's ability to rid the lungs of dust and germs. Because the cilia no longer function properly, the pooled mucus is also difficult to clear. Lung infections are common. A person may be born with bronchiectasis or may acquire it later in life as a result of other lung disorders. The main symptom of bronchiectasis is a constant cough that produces a lot of phlegm and mucus. Although the patient generally feels well, without fever or pain, fatigue, weight loss, shortness of breath, and wheezing can also be present.
So I thought it was easier to explain if you see that. So as you can see, bronchiectasis, I'm going to go back, is when the airways get changed like that. They get big, the normal clearance mechanisms are affected, a lot of mucus stays into the airway, and people have, as you can imagine, chronic cough and a lot of sputum production. Now, there are many diseases that can cause bronchiectasis, but alpha-1 is there. And that's why every time we see somebody with bronchiectasis, we test for alpha-1. Now, these are the symptoms: cough, sputum production, shortness of breath. Sometimes people can cough up blood. People can get fatigue. But as you can imagine, these are non-specific symptoms because you can just have COPD with chronic bronchitis and have symptoms similar to this. Now, if you see it in a picture, and I know most of you don't know how to look at CAT scans, but you can see these big holes here. Anybody can see them. Those are big airways that should not look like that. And those airways are bronchiectasis. Now, if your physician suspects bronchiectasis, usually they have to order this, a high-resolution CAT scan. Not this type of CAT scan. It's called high resolution. We have many types of CAT scans that we can do, but the high resolution is the one that allows us to see the airways better. Now, also, when we see people with bronchiectasis, we have to make sure they don't have acid reflux, because we believe part of the reason why some people get bronchiectasis is because the acid reflux, gets swallowed and gets aspirated into the airway, goes down to the lungs and starts damaging the airways. So this is just a study showing that the prevalence of acid reflux is higher in people with bronchiectasis than people without bronchiectasis. Now, what's the relation with Alpha-1? The only good study I found out there is from Dr. Stockley in England that did CAT scans in 74 patients with Alpha-1, and he found that 70 of them have already some bronchiectasis. And 1/3 of them had what he calls significant bronchiectasis, which was involving different parts of the lung. And this is how it looks in one of the pictures that he showed. Now, the worse the airway problem, the worse the quality of life of the person. And that makes sense. So the problem with bronchiectasis, as you can imagine, is infection. These bugs get into those airways and they cannot come out because the airways are full of mucus and that mucus cannot be expectorated. The classic bug that we normally isolate is a bacteria called Pseudomonas. But the one that I want to emphasize, and just to finalize, is this one called Mycobacterium. And what is Mycobacterium? Mycobacterium is a family of bacteria. And we call them non-tuberculous mycobacteria because mycobacteria can do many types of diseases. One of them is tuberculosis. But I'm not talking about tuberculosis, which is very common around the world. I'm talking about the non-tuberculosis mycobacteria, and we call it NTM. These non-tuberculous mycobacteria are found everywhere, in the soil, in the environment, in the showers. So people tend to get it just by doing their normal activities. Leprosy is another disease caused by mycobacteria. But the one that is prevalent, the one that we see a lot, is the MTMs. We have different types. One is called the avium, one is called the abscessus. We tend to call them RGMs, which are the rapid growing. And the problem is that if you don't look for it, or you don't think about it, I'm talking for as a physician, you're never going to find it. The way to diagnose it is by isolating this mycobacteria from sputum or from airway samples. It's strongly associated with Alpha-1, and this is a publication from National Jewish showing that if you have non-tuberculous mycobacterial infection, you're going to have a higher prevalence of having abnormal Alpha-1 genes. So there is a direct relation. Why do we think this happens? Because in the lab, you can add Alpha-1 to a mycobacteria, and that mycobacteria is not going to infect the white cells. So Alpha-1 is protecting our body against mycobacteria. And that's why when you have an abnormal Alpha-1, you have a lot of mycobacteria. So remember, mycobacteria are strongly related to bronchiectasis. It can produce a lot of chronic symptoms, the same thing as the bronchiectasis of cough and cough. You take your inhalers, you still have cough, you're still short of breath, you still have sputum production. Maybe it's because you have a mycobacteria in your lungs, and your physician needs to look for it. It's associated with both ZZ and MZs and other carrier conditions. The treatment takes months to years, and people have to take many antibiotics at a time. Usually we start with 3 antibiotics at a time. That's the only way to get rid of it. But remember, if you don't think about it, you're never going to have it diagnosed. And most people with mycobacteria, it's better if they are referred to a center with special expertise in treating these infections. And this is just to summarize. I hope I didn't scare you with all these conditions, but this is what's out there in the literature, and you might hear about it. Okay, so most of these diseases that I just mentioned are case reports, isolated conditions, or epidemiologic associations. But that doesn't mean that alphas get all of this. The one that I will just emphasize is if you have chronic symptoms, pulmonary symptoms, ask your physician if you might have bronchiectasis or mycobacteria in the lung. That's something that we see almost every day. And I think that's the last one. Yes, that's the last one. If you have any questions, you can email me. Thank you.